Everybody, and welcome to this Cardiology Mentorship program. My name is Dr. Widad. I'm cardiologist and assistant professor in cardiology in Tunisia. We are going to talk today about the assessment of left ventricular function and especially about the assessment of left ventricular diastolic function. Impairment of left ventricular diastolic function is common amongst those with left heart disease and is associated with significant morbidity. One half of hospitalization for heart failure are in those with preserved left ventricular ejection fraction, where abnormalities of ventricular filling are the cause of symptoms. It's clear that the assessment of left ventricular diastolic function is crucial for understanding global cardiac function and for identifying the wider effects of disease process. The high temporal resolution of transthoracic echocardiography with widely validated and reproducible measures available at the patient's bedside have established echocardiography as the primary imaging modality. The comprehensive assessment of left ventricular diastolic function is therefore a fundamental element of the standard TTE. For ventricular physiology, the left ventricular cardiac cycle is broadly divided into two phases, systole and diastole. Left ventricular systole, defined as the period between mitral valve closure and aortic valve closure, and consists of two phases that are termed according to the chances of left ventricular volume, isovolumetric contraction and the ejection phase. Diastole is defined as the period between atrioventricular closure and mitral valve closure and includes periods of isovolumetric relaxation and ventricular filling. In sensory, with normal heart rate and no conduction delay between the atria and ventricles, diastole is a four-phase process that comprises periods of isovolumetric relaxation, early rapid filling, a period of little or no filling, and atrial contraction. Given the multiple aspects of diastolic mechanics, there is no single parameter or measure that accurately describes ventricular diastolic function and the response of intracavity pressure. The echocardiography assessment of left ventricular diastole must therefore incorporate multiple parameters of intracardiac blood flow velocity, myocardial relaxation velocity, and left atrial size and function in order to consider the presence of degree of diastolic impairment. Routine echocardiography measures of left ventricular diastolic function. Transmittal E-wave. The transmittal Doppler E-wave represents early left ventricular filling from rapid relaxation, although measurement of peak E is not a direct measure of left atrial pressure when applying the simplified Bernoulli equation. The peak E velocity is determined by the left atrial to left ventricular pressure difference and is therefore reflective of left atrial pressure. E velocity therefore falls as left ventricular relaxation becomes impaired. The relationship between left ventricular diastolic function and E wave velocity is U-shaped, with E velocity falling in the early stages of diastolic impairment before increasing as disease progresses. Transmitter E deceleration time. E-wave deceleration measures the time between the peak early transmitter flow velocity, peak E, and the point when flow ends or the point at which atrial contraction occurs. Onset of mitral E deceleration corresponds to left atrial to left ventricular pressure crossover and reversal of the transmittal pressure gradient, which acts as a deceleration force. The early stages of impaired diastolic function are characterized by slowing in the rate of left ventricular relaxation with therefore extended E-wave deceleration time, as seen with normal aging, typically more than 220 milliseconds in those less than 50 years and more than 280 milliseconds in those more than 50 years. The early diastolic flow into an incomplete left ventricular causes left ventricular pressure to rise rapidly and left atrial left ventricular pressures to equalize quickly with a consequently rapid deceleration of flow. The A-wave deceleration time is therefore short, less than 150 milliseconds, when diastolic impairment is advanced and left ventricular filling pressure increased. The relationship between impaired left ventricular diastolic function and the E deceleration is inverse U-shaped, increased with impaired relaxation before decreasing as left ventricular filling pressure increases, with an inverse relationship between rising left atrial pressure and E deceleration time. Transmitter A wave velocity. In sine left ventricular filling concludes with atrial contraction in late diastole, represented as the transmittal A wave on Doppler imaging. A distensible and complete left ventricular is able to increase and diastolic volume with only a small increase in pressure. With normal diastolic function, the majority of total left ventricular filling occurs in early diastole with a small contribution of left atrial contraction to overall filling, usually 10 to 20%. With normal left ventricular compliance, the low pressure difference between the left atrial and the left ventricular in late diastole and the low volume contribution from left atrial contraction result in a transmittal A wave velocity that's typically lower than the E wave velocity. EA ratio. The ratio of transmittal E and A velocities reflects the ratio of early and late left ventricular diastolic filling. The EA ratio in young, healthy individuals is therefore typically more than 1. Natural aging leads to a slower rate of left ventricular relaxation with a reduction in the early diastolic filling volume and fall in E velocity. Normal stroke volume is maintained by an increase in the atrial contraction filling volume. This increase in atrial contraction volume is reflected by an increase in A velocity to exceed E velocity and therefore a shift in the EA ratio to less than 1. Early diastolic mitral annular tissue Doppler imaging (TTI) prime. In the healthy heart of the young and middle-aged, mitral valve annular velocities are high during both systolic descent and diastolic ascent, reflecting the dynamic function of both the left atrial and left ventricular. E prime ratio. Progressive of impaired diastolic function is characterized by worsening of left ventricular relaxation with partial reduction of E prime velocity and decreasing left ventricular compliance, leading to elevated left ventricular filling pressure and therefore increased E velocity. An increased E prime velocity ratio is therefore a marker for increased left ventricular filling pressure and left atrial pressure. A value less than 8 is specific for normal left ventricular filling pressure, and an average of septal and lateral E prime ratio more than 14 is highly specific for a raised left ventricular filling pressure. An E prime ratio more than 14 is therefore a supportive finding for elevated left ventricular filling pressure for the majority of individuals across all age groups and certainly in those less than 40 years. For left atrial volume, in the normal healthy heart, the left atrial is a thin-walled chamber that functions under low pressure, usually at a mean of around 8 mm per mercury. Although left atrial dilatation is present in the vast majority of patients with elevated left atrial pressure, not all patients with large left atrial have elevated left atrial pressure. Other causes of left atrial dilation should always be excluded, including atrial arrhythmia, significant mitral valve disease, transplanted hearts, bradycardia, ventricular septal defects, aesthetic remodeling, and high output states. Left atrial volume does not exceed 34 milliliter per square meter when indexed to body surface area. Regurgitation velocity. The continuity between the left atrium, pulmonary veins, and the pulmonary capillary system causes elevation of left atrial pressure to be transmitted through the pulmonary vasculature, leading to elevated pulmonary pressures. Therefore, in the absence of other causes of pulmonary hypertension, the velocity of tricuspid regurgitation can be considered indicative of systolic pulmonary artery pressure and therefore incorporated into the assessment of left ventricular diastolic function and estimation of left ventricular filling pressure. Left atrial function strain analysis. The analysis of left atrial strain (LAS) provides parameters for all phases of left atrial function, the reservoir phase, LARS, and pump phase (LAPS) being important for the assessment of left ventricular diastolic function. We see the normal reference intervals for left atrial reservoir and pump strain. Supplementary parameters of left ventricular diastolic function should be known, like pulmonary vein flow, transmitter airwave duration, PPS-PVT ratio, and systolic fraction, deceleration of PPS slope, PVT deceleration slope, PV air velocity, and duration. Though the following parameters are not recommended for routine clinical practice, they may provide insight into left ventricular diastolic function in certain scenarios. Middle unenriched Doppler imaging, TDI, E prime ratio, IVRT, velocity propagation, EVP ratio, IVRT, E prime ratio, A wave transit time. Algorithms were established to simplify the assessment of left ventricular diastolic function. For patients with normal systolic function, the assessment centers on three key variables: EE prime more than 40, tricuspid regurgitation velocity more than 2.8 meters per second and indexed left atrial volume more than 34 milliliter per square meter. When 2 or 3 of these parameters are negative, left ventricular filling pressure are considered normal. If 2 or 3 parameters are positive, diastolic function is impaired and left ventricular filling pressure are elevated. When only 2 criteria are available with 1 positive and 1 negative, the missing parameter can be replaced by left atrial strain. High normal values of LARS more than 30% and LAPS more than 30% indicate normal left ventricular filling pressure with very high accuracy. Left ventricular relaxation should then be reported according to age-specific ETY. As diastolic impairment progresses and left ventricular filling pressure increases, parameters of left atrial function typically deteriorate. LARS less than 80% is suggestive of elevated left ventricular filling pressure. For patients with impaired systolic function or non-myocardial disease, we have the same step 1 with the E prime ratio, left atrial volume, and tricuspid regurgitation. When only 2 criteria are available with 1 positive and 1 negative, the missing parameter can be replaced by left atrial strain. The cutoffs of left atrial strain are different to those with normal left ventricular ejection fraction. In this case, absolute lapse less than 8% or LARS less than 80% indicate elevated left ventricular filling pressure, while more than 40% and more than 24% indicate normal left ventricular filling pressure with high accuracy. Due to the overlap in left atrial strain parameters between normal and elevated left ventricular filling pressure, LAPS values of 8 to 30% and LARS between 18 and 23% may be seen in the setting of both normal and elevated left ventricular filling pressure, and supplementary parameters should be considered. This algorithm for the assessment of left ventricular diastolic function should be used in all patients in atrial fibrillation, irrespective of left ventricular systolic function. Step 1 incorporates 4 key variables: septal E prime ratio, mitral valve E velocity, mitral valve E deceleration time, and tricuspid regurgitation velocity. When more than 3 parameters are positive, left ventricular filling pressure are considered elevated. When more than 3 are negative, left ventricular filling pressure are considered normal. In scenarios where less than 3 parameters are available and only less than 2 are positive or negative, filling pressures are unclassified and partial supplementary parameters should be considered in step 2. LARS, PVST ratio, and BMI. When more than 2 of these are positive, filling pressures are considered elevated. When less than 2 are more than 2 are negative, filling pressures are considered normal. If these criteria in step 2 are not met, left ventricular filling pressure are indeterminate. To conclude, The assessment of left ventricular diastolic function is complex, requiring a multi-parametric approach to the investigation of relaxation, chamber compliance, and feeding pressure. However, by considering the group commentation alongside the patient's clinical presentation, a successful investigation of diastolic function and left ventricular filling pressure is possible in most patients. Thank you for your attention.